Welcome, everybody. This is our 22nd annual conference. The format is very different this year. My name is Michael Sago. I'm the director of the Center for Clinical Ethics. And we've been sort of doing these conferences for, again, 22 years. And this is the first time we have not had sort of an in-person full day event. We decided to change our format into more of a speaker series over the next 3 weeks due to the pandemic. And again, we're hoping to be able to sort of provide some education. This is our signature event every year in a little bit of a different format, which will hopefully be respectful of both people's time and Zoom fatigue. The Center for Clinical Ethics is based at Unity Health Toronto, but we also provide ethics services to 6 other healthcare organizations representing more than 4,400 beds. So I'd like to welcome all of those who are joining us from Lakeridge Health, Scarborough Health Network, Waypoint Center for Mental Health, Runnymede Healthcare, Toronto Grace Healthcare, St. Joe's Hamilton, and of course, Unity Health Toronto. I'd like to begin with a land acknowledgement. I'd like to acknowledge that the land we gather in the traditional territory of the Haudenosaunee, and more recently, the territory of the Mississaugas of the New Credit First Nation. This territory was subject of the agreement between the Iroquois Confederacy and the Ojibwe and allied nations to peaceably share and care for resources around the Great Lakes. This territory is also covered by the Upper Canada Treaties. Today, it is still home to many Indigenous people from across Turtle Island, and we are thankful to have the opportunity to work in this community on this territory. It is our collective responsibility to recognize this land as traditional territory. With gratitude, we say miigwech to thank the Haudenosaunee, Mississaugas, and other Indigenous peoples for taking care of this land from time immemorial and for sharing this land for those of us who are newcomers. Out of this gratitude, we are called to treat the land, its plants, animals, stories, and its peoples with honor and respect. So the theme of this year's seminar series is Confronting Injustice, Exploring Ethical Issues Raised During COVID-19. We know that COVID-19 has sort of further amplified the social inequities that were present before COVID, and we really hope to spend the next few weeks shining a light on some of those issues. Today, I'm privileged to introduce our speaker panel, Dr. Roberta Timothy, Lieben Gabramichael, and Melissa Stevenson, who will be speaking of the impact of COVID-19 on racialized communities. The way we're going to organize the next hour and a half is each speaker will roughly have about 20 minutes. I'll let the speakers know when they've got about 3 minutes remaining, just as a reminder. And then there'll be 30 minutes for a Q&A at the end of the sort of the speaking session. I'll ask you to use the Q&A function to write in your written requests, and I'll sort of help moderate the discussion. So without further ado, I'd like to introduce our first speaker, Dr. Roberta Timothy. Dr. Timothy is an assistant professor in the teaching stream and the new director of health promotion at the Dalai Lama School of Public Health at the University of Toronto. She's also an adjunct professor in critical disability studies at York University. She specializes in areas of intersectionality and ethics in health work, health and race, art-based methodologies, transnational Indigenous health, and anti-oppression, anti-colonial approaches to mental health. Dr. Timothy has worked for over 30 years in community health, working on resisting anti-Black racism and intersectional violence strategies. Dr. Timothy is also the co-founder and consultant at Continuing Healing Consultants, where she implements and teaches her intersectional mental health model, anti-oppression psychotherapy. She is an interdisciplinary scholar, health practitioner, and political scientist who examines global health and ethics from her critical trauma-informed decolonizing framework. She's been living with disabilities for over 25 years, and thank you so much for spending some time with us this afternoon. I'll hand it over to you.
Thanks, Michael. I'm just going to share my screen and okay. Started. Trying to. Okay, so you started with the land acknowledgement, so I just wanted to also just have a quickly talk about Indigenous Solidarity Statement. I stand in solidarity with the Indigenous peoples of these lands and support in their fight for reparations and self-determination, as I know that their struggles are intrinsically related to my own people's fight for justice and reparations, as we are linked through processes of genocide, white supremacy, colonization, and enslavement. I vow that even though we have differences among ourselves, that the divide and conquer supported, sustained, and fueled by the Canadian state through systemic oppressions maintained by colonial powers and white supremacist ideologies will not dictate or reconfigure my connection with Indigenous, African, Black, and colonized people locally and globally. I also just want to do an ancestral acknowledgement. We honor our ancestors of African descent who are intrinsically linked to this land and who fought for their survival. Their lessons and sacrifices have led us to gather here today. We ask you that you take a minute to reflect and honor our ancestors, those who have now journeyed, who provide the footprints on which we stand today. So just a little bit of my location. I identify as an African diasporic woman, womanist, feminist, surviving enslavement from a working class background, daughter of immigrants via the Caribbean and Latin America, mother of two, living and resisting with a visual disability in Turtle Island. I also have taught health ethics and social determinants of health, global health, and teach from a decolonizing perspective. I also want to recognize that this is the decade for people of African descent, 2015 to 2024. So it's really important to understand that the work that we're talking about in terms of dealing with health disparities and anti-Black racism and the impact of COVID is actually coming in the era of the decade for recognizing people of African descent. So I want to share my definition of ethics. I'm not going to go to and talk about the kind of the moral principles, the five ethical principles, which I do and can unpack in other ways from a anti-colonial perspective, but I want to start with my definition of ethics. So ethics for me is ideologies, policies, and practices, including data science, that examine the historical and current day colonial and intersectional violence and injustices of government, structures, individuals, and groups, including research. It gives moral judgment to stop the inhumane treatment through omission or surveillance of known realities of cruelty and unjust experiences of Black, Indigenous, racialized, and marginalized populations. Ethical conduct must include an intersectional decolonizing practice by providing reconciliation and reparations to create morally just outcomes, to address any wrongdoings, and to denounce what is morally wrong and uphold what is morally right through direct anti-racist, anti-violence action in societies, including collecting socially responsible data. Just want to also give a definition of anti-Black racism. Is racism or racist trauma directed specifically towards African Black people based on the promulgation of colonial violence and sanctioned by eugenics-based racial stereotypes that create particular unjust relationships between African Black communities and white supremacist state structures and practices. So I want to talk quickly about, briefly about before COVID-19, and I'm going to mention Black communities and also Indigenous communities because Indigenous and African communities are connected intrinsically based on colonization. So if we look at the global context of health inequities in African Black communities, there's this quote that I want to share. Today, there is a 36-year gap in life expectancy between countries. A child born in Malawi can expect to live for only 47 years, while a child born in Japan could live for as long as 83 years. In Chad, every fifth child dies before they reach the age of 5, while in the WHO European region, the under 5 mortality rate is 13 out of 1,000. There's no biological or genetic reason for these alarming differences in health and life opportunity. In Canada, in terms of Black population among ethnic communities, Black women have had the most drastic increased rates of high blood pressure, increasing from 20% in 2001 to 27% in 2012. 1 in 7 people living with HIV in Canada, 15% is African Black. 41% of all children and youth are in care apprehended by the Toronto Children's Aid Society are Black. If you're Black in Halifax, you're 6 times more likely to be carded by police compared to white counterparts. In terms of Indigenous communities in Canada and health impact, 82% of Inuit living in Inuit Nunavut reported that they did not have a family doctor. In comparison, less than 1 in 5 Canadians did not have a family doctor. Among First Nations adults aged 50 and older living off reserve, 36% reported having high blood pressure and 20% reported having diabetes, in comparison to 33% of all Canadians aged 50 and older. I want to give that context because it's important to understand that the health impacts before COVID were pretty critical in African Black Indigenous communities. And I just want to briefly now talk about the historical context of health equities, so how this exists. So I want to talk about, first of all, this map shows the transatlantic slave trade, which is critical to the continuation of colonial violence and anti-Black racism in the lives of African peoples. Also the slave trade in East Africa, 17th century, which is not often mentioned, but it also has an impact on anti-Black racism and health inequities locally and globally. This is an example of a Kent Monkman's photo in terms of recognizing the colonization of Indigenous peoples in Canada and the anti-Indigenous racism that occurs in Canada and the impact on health. Slavery existed in Canada, and this is just an example to talk about the history of enslavement and how it has impacted health disparities today. I quickly want to talk about historical scientific racism and experiments, because this directly relates to unethical data. And if we look at COVID-19, what's happening today, there is a connection between historical and current day scientific racism and experiments. Most folks know about the Nestle formula boycott in the 70s, and this is just an example of the baby killer ad, where Nestle went to mainly developing countries and gave women formula to use instead of breast milk, and had really detrimental results. So I want to talk about just briefly that the history of unethical data collection and ethical relations to Black communities starts way back in terms of enslaved Africans and experiments that were done to enslaved African folks. One example is the smallpox inoculation in a population of 850 enslaved folks during the 1768 epidemic in Jamaica from British colonial rule. Also Indigenous residential school nutrition experiments, Indigenous sanitarium survivor experiments, Shark Island concentration camps experiments, which was in 1904, 1906, which is now called Namibia, which is really critical because it predated Holocaust experiments in Germany. The Tuskegee syphilis trials in Alabama, Guatemala syphilis experiments, Henrietta Lacks using her cells without permission, institutionalization and sterilization of people living with disabilities, to name a few. Again, I did the heroin and genocide. Eradication of Black cancer patients, 1960 until 1971. Forced contraception in Rhodesia, now Zimbabwe, which is in 1970s. This is really critical when looking at the Depo-Provera and what's going to happen with the vaccines and the history of mistrust with the Black community. HIV/AIDS testing in Zimbabwe and meningitis testing in Nigeria as our few local and global examples. Also looking at some key unethical Canadian policies and practices and institutions that impact health for African, Indigenous, and marginalized populations. Genocide, transatlantic slave trade, Indian Act, British North American Act, the right to vote, 60s scope, racialized immigration policies, Chinese Exclusion Act, Komagatu Maru, Japanese internment camps, criminalization of homosexuality until 1969, bathhouse raids and gay bars, Haitian and Vietnamese boat people, to name a few. You can also talk about the criminalization of marijuana, cannabis in 2018 as a recent example of unethical policies that impact Black communities and Black health. So I quickly want to talk about what's happening during COVID. So during COVID-19, there is also uprising happening in terms of increased police brutality and anti-Black racism. And it kind of tells you the level of violence in the Black community that folks are actually, during a 100-year pandemic, people are protesting. But I really just wanted to put that context, because it's critical to understanding how ethical and unethical practices and how unethical the response is to anti-Black racism and to COVID-19, hence people's protesting in the streets for different types of violence against Black communities. So there's around 56,583,000 cases of COVID-19, 312,000 cases in Canada. I also want to talk about the context of COVID-19 in the Canadian context. Is a context where Indigenous folks are being murdered or dying without dignity and dying with the impact of anti-Indigenous racism. And this is just a picture of Joyce Ekogwan, who died while Indigenous and seeking care in the hospital in September 2020. Also, just want to give another example of dying while Black and Indigenous living with mental health in Toronto, May Regis Kurtinsky Peget, and there's many, many more that have lost their lives during this period of time. So the connection between anti-Black racism and COVID-19 and health inequities is really important to look at. I am giving some statistics just quickly on different race-based data because I want to make a point at the end. So this is for UK. Black males are 4.2 times more likely to die from COVID-19 related death, and Black females are 4.3 times more likely than white ethnicity males and females. In the States, 46,211 Black Americans are known to have lost their lives to COVID-19 through Tuesday, November 10th. 48,112 deaths in the African continent. 1 in 925 Indigenous American has died, or 0.3 deaths per 100,000, and 1 in 1,275 Latino Americans have died. And again, the Latin American collection, we also don't know how it can be divided in terms of Indigenous and African descent also. In terms of the Canadian context, 21% of reported cases affect Black people, who make up only 9% of the city's overall population, and Black people and other people of color make up 83% of reported COVID-19 cases in Toronto. And this is really important because in the beginning of the pandemic, when we were, myself and many other Black community health leaders were talking about race-based data, we were told by the government and public health that race-based data wasn't important and necessary. And in a survey of 2,300 adults, participants who identified as Black reported both poor health outcomes and more financial distress than other respondents this during COVID. Although Black Canadians experienced only slightly higher rates of COVID symptoms, they were 3 times more likely to report knowing someone who died from the virus. And that's true. Most of us know my nephew died from COVID outside of Canada, and I know many folks who have had losses. And the grief in our community is also a real important thing to understand in terms of responding to COVID ethically. So talking about race-based data and COVID-19 ethics, I just want to spend a minute here. So in Canada, we have lack of race-based data and intersectional data. Intersectional data, I mean class, gender, sexual orientation, age, disability, and other intersexual factors. And there's limited interventions that directly address impact of COVID-19 in African Black communities. Community health centers and community organizations are trying and doing a lot of work, but they're still not well-resourced. And I want to kind of show the kind of comparison of race-based data in the States. So there's a lot of race-based data in the States. However, there's still little intervention that directly addresses and impacts COVID-19 on African Black people. In the UK, there's a lack of race-based data, and there's not also a lot of intervention. There's also no race-based data, or very limited race-based data in Brazil, which is really important for African populations, France, Germany, Spain, and other parts of Europe, Middle East, Central and South America. So the connection is, is race-based data important for African Black communities dealing with COVID-19? And if it is, what is the impact? And what I mean by that is, it's important if it comes with interventions and strategies for change that will actually support our community. And it's also important to understand that our community is very heterogeneous, and it's really critical to create any type of interventions that actually deal with the heterogeneous notion of Black and African communities. And of course, African continent, with the exception of South Africa, Morocco, and Egypt, are doing fairly well in terms of numbers, and I'm talking about based on the population of 1 billion in the continent. Intervention strategies would be really important to look at the intervention strategies that are occurring globally for Black communities, and also look at how we can look at some of those interventions in the Canadian context. So these are just some more statistics about folks' experiences during COVID-19. Among Indigenous participants who experienced discrimination over the course of the pandemic, the most common form was discrimination based on Indigenous identity. However, other forms were also reported, including discrimination based on physical appearance, etc. Among Black participants who experienced discrimination, 84% reported that they had experienced discrimination related to race or skin color. So that we understand there's a deep connection between anti-Black racism and their experience during the COVID era. Some more statistics. So I just want to quickly talk about Black, Indigenous, racialized, and marginalized communities and health impacts. So underlying conditions related to racism, intersectional violence, and transgenerational trauma equals increased risk. Mistrust in the healthcare system due to past experiences and current experiences of health violence is critical to understand. Biases by health practitioners, working in low-paying jobs and food insecurity, Overrepresentation in service provider work, PSW, migrant, cleaning, et cetera, is critical to understand when we're thinking about the unethical or ethical dilemmas within COVID-19. Racial profiling and police surveillance, which is still on the rise, overcrowding in housing, and also the connection to ageist and ableist dialogues, which are not connected because they usually don't have an intersectional focus. Inequities and unethical policies and recommendations in response to COVID-19 planning and management are critical to also understand. The lack of race-based data and intersectional data is important. The lack of rent freeze, the overrepresentation of migrants undocumented and imprisoned, business loans not focusing on informal work, lack of policies related directly to racism and intersectional violence, social distancing challenges not addressed, children in CAS, families, violence against women, mental health impact not addressed from an anti-oppression lens, it should say, risk-based on violence, example, wearing masks, wage increase not covering low-paying essential workers, housing, education, and work apartheid, and high priority neighborhoods labeled but resources and interventions not given. And this is a critical piece. We've been hearing a lot about the high priority neighborhoods. I live in Kiel and Wilson, and it's supposed to be a high prevalence neighborhood, but the interventions and the resources are not being given in the community. And I think that's a critical piece. So how to challenge and change our current unethical responses to COVID-19 in the lives of Black, Indigenous, racialized, and purposely marginalized communities. One, recognize that unethical relations exist between the Canadian state and racialized populations through government, public health, media, and other institutions. Two, collect race-based data and intersectional data that can be analyzed by communities who are impacted by unethical practices for interventions by and for our communities to actually provide supports. Give us resources, we will use them. Make ethical decisions that support the health and safety of marginalized populations, not further hindering them. It is not only about ventilator allocation. 4, understanding the impact of COVID-19 on our community's health and committing to do and act differently is critical. And 5, to decolonize data collection, analysis, research, and healthcare and interventions is all important to doing more ethical responses to COVID-19. And I just want to end with a project that I am the PI for. And this project came from basically not having race data and intersectional data in our communities, and really wanting it to be led by our community. So I am doing a Black Health Matters National and Transnational COVID-19 Impact Resistance and Intervention Strategy Project. We are launching a survey at the end of the month, or December for the latest, and we are trying to create our own database that collects data in terms of the impact of Black folks locally and globally, because we as Black folks, we're connected transnationally, and also looking at intervention strategies and also looking at resistance, how Black folks are fighting back. So that's all I have for today. Thank you so much.
Thank you so much.
So I think now we'll, hello everybody. My name is Sean Hillman. I'm one of the ethicists at the Center for Clinical Ethics, serving the Durham region through Lake Ridge Health. I have the great honor to introduce our next speaker, Melissa Stevenson. Melissa is Bear Clan. She is from the Peguis First Nation, which is an Ojibwe Cree reserve in Manitoba. Melissa is a mom to 3 amazing little boys who fill her heart with love. She currently works at Anishinaabe Health Toronto as Washkishu-Yan Unit Coordinator, where Melissa supports her community and staff to find ways to integrate the balance between traditional and Western ways of knowing and provide whole person care to the Indigenous community in the Greater Toronto area. Melissa has spent much of her post-secondary education and professional career working with Indigenous health and research. She has worked as a volunteer research assistant since 2010 with a nursing professor from a local university. Through the research and her work at Anishinaabe Health Toronto, Melissa has presented at various professional conferences. She is currently enrolled in the Masters of Nursing program thesis stream at Athabasca University with a focus on Indigenous diabetes care and traditional ways of knowing. Our personal connection is through my wife, Alexandra, who is an NP at Anishinaabe Health, and I look forward to hearing what Melissa has to share with us. Thank you so much for being here, and we'll pass the floor to you now.
Thank you. Thank you, Sean. It's always so funny having introductions done for you. Bonjour, I'm just gonna start myself as well. Bonjour, Melissa Stevenson, Anishinaabe, Makwadotum, Peguis First Nation in Dojiba, but currently reside in Mississauga with my family. I just like to start myself and ground myself in my language just to kind of help set the stage for our conversation we're about to have regarding I guess our COVID-19 response, both within our organization and as a community. So I will just share my screen. Give me 1 second. And I have to say, Roberta, thank you so much. That presentation was very amazing and informative. You covered a lot of the national stuff, which is really great. Slideshow, hold on. Thank you very much. Okay. So again, looking at the COVID-19 response and our Indigenous community, I thought one piece that I would start with here is, obviously I'll talk a bit about Anishinaabe Health. It's an accredited community health center. We were established in '84, and it was basically a call out from a community getting together and identifying, you know, one of our biggest needs back then was definitely a lot of our community was coming into the city and they were looking for Indigenous services to address especially diabetes care, and you know, at the helm was Joe Sylvester, and he was able to get this organization established and incorporated in '84, and it basically was a response, very grassroots based, because it was a response for the community at the time. Our mission is, of course, to improve the health and well-being of our community through mind, body, spirit, and emotion. And we really support this through an integrated approach of traditional and Western ways of knowing. And so we find that fine balance using both, as many may have heard before, you know, the term is called two-eyed seeing, and it's basically finding a way to support both culture and Western ways of knowing to help support our community in regaining. A lot of it comes down to, I think, culture and identity, I think, which is really helpful in helping us understand who we are and then how we can kind of cope and continue to maintain our wellness. And again, you know, we really highlight that our traditional traditions, our beliefs, and our ceremonies are really at the heart of it all. Obviously, you know, things are a bit different these days, regards to the ceremony especially, but we are doing our best to continue to support the community for sure. I looked at I thought it would be good to kind of set the stage as well for our community. I mean, a lot of people I'm sure have read these stats before. I'm covering some very important information that came from an important report that came out in 2016 calling our health counts. And so, yeah, highlighting in 2016, it was just over 46,000 people were identified as Indigenous living in the Greater Toronto Area. The Indigenous communities kind of saw it differently, and they kind of got together and tried to understand who was accessing services. And so their number was closer to 70. So again, obviously there was a huge disparity, and a lot of it comes down to the fact that, you know, our community tends to, you know, travel to see what's, you know, based on what's best fit for their time in their life at that time. And so sometimes they stay with family and friends, whereas when they try to collect some of this data from for the census and that, it's all based on addresses. So you don't get a really good number of who in our community is living in the area. So again, it's a much higher than what it was originally anticipated. Our health, again, really highlighting the disparities. I don't normally like to focus on this, but I figured this was a piece to kind of set the stage. So knowing obviously that we have 2 to 5 times higher chronic illness diagnosis as compared to the general population. You know, diabetes 3 to 5 times higher. Again, it's almost like an expectation in some people's lives that diabetes is going to be in their future, which is not always the greatest thing. Again, we're really trying to combat that belief and have people understand that they can attain wellness. Again, looking at the prevalence of health conditions, it can be really linked to a lot of issues. Again, we talk a lot about social determinants of health and how they're linked to it all, you know, looking at the overburden again of poverty, knowing the majority of our community do live at or below the poverty line. A lot of them live in adverse housing. Basically, either there are multiple people living in the house, or they're even trying to maintain their house, and then at some points even experiencing homelessness, which is an important consideration, again, for their overall health, because housing is definitely one of those, you know, main needs for sure. And then racism, I think this is a real huge one. You know, Roberta mentioned Jocelyn, and it's an important consideration. It still terrifies me that, you know, this day and age, we are still having our community face the amount of racism that they are. And so even within this report, they also identified that at least 54 have experienced racism when accessing health, or even accessing any services generally. Again, looking at chronic illness, you know, within 65% identifies having one or more, and within that 35% still identifying having two or more comorbidities. Knowing, again, like this is, it's a really high in comparison to the general population. Also knowing that, you know, 15% have been told that they had diabetes, which is another very important consideration ongoing, is making sure that they're these community or these group are accessing services to address their needs related to their diabetes. Again, roadblocks, really highlighting roadblocks to wellness. You know, as Roberta spoke about the different issues that are in place, one for sure is this issue of racism, both systemically, even within health settings as well. Again, highlighting that this report identified that 1 in 4 people have experienced racism in a health setting, and 74% of them have identified or prevented or stopped or delayed them from accessing services. This is such a true piece, and I can tell from even within my own practice of working with clients and trying to understand, you know, as providers, we're trying to ensure that our clients get access to the specialties or the services that they need, but there's so many times that they refuse to go, and it's always, you know, our attempt to try to understand why they're refusing to go. And a lot of times when you kind of are able to break it down for the client, or even have that conversation with the client and create that safe space, and they're able to open up, a lot of it comes down to that, is they don't like going to some of these other specialties just because they don't feel comfortable. And so it's trying to find a way to you know, bridge that gap, I suppose, and ensure that we are meeting, we're getting the services for our clients. Looking at our health in our hands, you know, just coming from the context of how we kind of see our health ourselves. And this is kind of coming from, you know, years within my practice working in diabetes before I became the unit coordinator here, as well as in some of the research and some of the work I've done. This is kind of like my view of how we see it all, my work with the healers as well. So obviously I know everyone will have a slightly different view of things, and that's the important piece of us and our identity and how we view it all, because we are a part of that sacredness. So looking at traditional teachings related to our health and wellness, I'm sure many have heard the medicine wheel teachings. Again, it's a fairly common, I guess, teaching that we try to use, and it's an attempt at us explaining to others on how we can better understand ourselves, how we see ourselves. I've often been reminded that this is a post-colonial teaching for sure. It's not something that was that we've had ongoing, because we just always saw ourselves in these different aspects of self. And it's not like the, you know, how we present the quadrant, like it's not, we don't have different quadrants. Like I can't tell that this part is this part necessarily, but it's more of a mosaic, and they're all very interconnected. And you know, it's kind of, I find it's a really great tool as even healthcare providers to use in when engaging with my clients. I know I've used it a number of times with diabetes care, because I honestly will ask clients and check in and see how they're doing in these different quadrants of self, for sure. Another really great teaching that I know I've often used in discussion and in understanding our health is the 7 grandfather teachings. This is basically a sacred teaching that we have related to us being able to live our life in the most respectful and appropriate way. You know, I've heard terminologies of living the red road, or living that sweetgrass trail. It's really how we are attempting to attain ourselves. So ensuring that we're living with that love, respect, that truth, that honesty, bravery, wisdom, and humility. And again, our traditional teachings, in our teachings, all the teachings that I've gotten, it really identifies that illness really starts in the spirit. And I mean, when you look at our history of our people and kind of what we've gone through over the years, you know, since post-colonial and you know, and when you look at the complexity of our health today, it's really easy to understand the different aspects that may be at play here. And you know, I've heard traditional people talk about, you know, it's a repair of a relationship that needs to happen somewhere down the bloodline. It may not directly be me, but you know, this idea of intergenerational trauma is the piece that's connected it all back together. So knowing that a lot of this spiritual work is what's needed, and finding that safe space for the clients to do that work if it's of their interest, for sure. I also recognize the diversity of our community as well, and some of them may not align with some of the cultural and traditional beliefs, and that's okay as well. We definitely really meet the client kind of where they are in it all. But also highlighting again that our physical body is basically that last space to experience this illness. So again, hence why our physical health tends to be a bit more complex. So looking at Anishinaabe Health's attempt to respond to this ongoing stuff, you know, I talk about like a lot of our teachings and a lot of different pieces that have been addressed, you know, throughout the community related to this COVID response. You know, I want to obviously highlight that one big piece too is important consideration is our health in our hands, as I said in the previous slide. And so our attempt to address the current ongoing pandemic in that we've been able to establish a mobile healing unit, and it's basically currently just providing COVID testing out in the community. Again, the great thing, I mean, it's a beautiful RV. It has a picture there with some beautiful artwork that's been done by a local artist, and it again travels throughout the downtown area in different areas to support the community in general. So it sees anyone and everyone who's looking to get a COVID testing done. Looking at our unit again, it has a nurse practitioner, a social worker, and a housing worker. We try to ensure that we have a lot of different staff on there to support the needs of our community. As to date, we have performed over 4,500 tests. And again, like I said, we basically travel wherever we need to go. We do visit a lot of the encampment areas to ensure that we are, one, identifying our community and ensuring that they are getting the services that they need, but also, again, finding ways to meet the need of the community generally, Indigenous, non-Indigenous. I think the attempt is just to, you know, we have a lot of stuff with this current pandemic going on, and it's important that all communities, all nations, everyone really takes the time to help address this need, because it's affecting all of us for sure. Again, like I say, you know, our ongoing response to this space right now is, again, we are just trying to get out into the community and identify our community, make sure that they're being connected. I know housing is an ongoing concern for sure, but really trying to work with our communities where they are and support them in that way. Within our clinic, for sure, like most centers, we do offer virtual services. We also do recognize that, you know, sometimes if a client really does need to come in, we will have them come in as needed. It's really based on where they are within their own care and understanding what their needs may be. We also have a charitable arm, our Anishinaabe Health Foundation. This is basically established to help us in building our future, in moving to our new space in a few years. So they basically have kind of switched gears a little bit, where they've now gone a bit more into finding ways to help our community during this pandemic. And so they've done a number of food basket deliveries, like most Indigenous organizations I think have done throughout the city as well, really trying to find ways to ensure food security during this time and meeting the needs of the community as needed. Mine was short and sweet. I just want to say thank you again for taking the time to listen to me chat about a bit what's going on here. And I did want to share some contact information if anyone had any follow-up questions. But thank you. Dziękuję.
Thank you so much, Melissa, for all that you shared with us.
Thank you so much, Melissa. It's a great pleasure for me to introduce our next speaker. Liban Gamber Mikhail is the first executive director of Taibu Community Health Center and the first Black male executive director of a community health center in the province. Gamber Mikhail has over 25 years of experience in the primary healthcare sector, social services, mental health, and community capacity building and development fields. He has worked as a social worker, child and family therapist, project coordinator, and therapeutic group facilitator with various primary care and non-for-profit organizations working with racialized and marginalized populations. He holds an MA in migration, mental health, and social care from University of Kent, a master's certificate in healthcare management from Schulich School of Business at University of York, and he has also completed the Community Health Leadership Program at the Rotman School of Management. In June 2012, Gamber Mikhail received the prestigious Emerging Leaders Award from the Association of Ontario Health Centers. Since June 2020, Liban Gamber Mikhail has served as the president of the board of directors of the Alliance for Healthier Communities. And I'm very much looking forward to continuing the wonderful talks that we've had thus far with Liban. Welcome, Liban.
Thank you very much for the introduction and the bios. Just trying to see if I can share my screen. Are people seeing the screen? Yeah.
Yes, we can see it.
All right, thank you. And thank you for Dr. Timothy and also Melissa for your presentation. It's going to be a tall order for me to follow from that, but I'll try my best. But I think we're talking about a significant challenge that we're facing in our communities and in our times. We were thinking and talking about trying to get to the normal conditions, going back to normal conditions. I think that's too late now, and I don't know if there's going to be any way of going back. But particularly for certain communities, this has been significantly a challenge, and we've just seen for the presentation that passed before. And there may be some repetitions here, but I'll try my best to kind of add more information for a better conversation later on. Just as a brief information about our organization, Taibu Community Health Center was established about 12.5 years ago with the mandate to serve the Black communities across the GTA. It's unique in that sense as a community health center, but we also serve all our residents here in the Malvern neighborhood. And over the years, we've also added some focus on certain populations, the Francophone population in Scarborough, and also working with the Indigenous communities in Scarborough. We were offered an opportunity to serve the Indigenous communities through the LIN, as it happens, but last year, all CHCs, including the Association of the Healthier Communities, really passed a resolution to make sure that Indigenous health is in Indigenous hands. And as such, as an organization, we have worked to establish an advisory council here in Scarborough. They're called the Scarborough Indigenous Mental Wellness Advisory Council, and they are now responsible for the engagement, the planning, the decision-making, and the delivery of programs for Indigenous communities. And we're providing space, administrative support, and things like that to kind of respect the values of the organization. So, and the council is really doing quite a lot of work during this COVID period, including organizing food sovereignty programs and other traditional and cultural programs as well, virtually. Our principles and values for the organization is, community-led leadership, community-driven. Of course, Afrocentricity and quality are the value statements that we have. We're located in the northeast end of Scarborough, in the Malvern Mall, for people who know Scarborough. A beautiful place to be, despite all the media profiles that we get. But, the parent organization, the Black Health Alliance, really made sure that they wanted to locate an organization. And this was just at the back of the Summer of Guns, in early 2000, and wanted to locate the center within the community where we can really develop relationship and engage our communities.
I'm sorry to interrupt, but we only see your slides in the editing view, not in the full screen view.
So I don't know what I have to do.
You may just need to stop sharing and reshare the appropriate window. Yeah,
sorry.
Thank you.
Apologize.
Okay, that's better. Thank you.
Okay. I heard somebody talk about COVID acting like an X-ray, right? We all know, and it's been said, that COVID really is amplifying already existing health disparities and inequities that exist within various indigenous, Black, and racialized communities. And it's really showing us what has been happening for generations. And so that stuck to my mind, and in terms of how we are thinking of addressing this issue, supporting our communities, has always been through that lens. I know there are some numbers that were shared earlier on in terms of the data that is happening in our cities, and we know that the Black community is significantly impacted, and that is also reflected around gender differences and income as well. And if we did some race-based data or further disaggregation of the income data, it would really reflect that the racialized, indigenous, and Black communities are disproportionately impacted. The data has been discussed earlier on, so I would like to kind of move to some of the maps that we know of. So this is, I think it's September, up to September, the map that the city is showing around where COVID incidences are taking place. And what has been significant for me is, if we overlay other kind of disparities or maps around the different kind of disparities that we see, maybe I should let you see it, right? So if you see the darker colors, you will see where things are, right? So this is from the Diabetes Atlas, showing the incidence of diabetes in our communities, right? And then if you look at where the Black community is residing, this is 2016 census. And then if people remember the tale of three cities and showing poverty around the city, this was the map that they showed around 2005. And this is the projection in 2025. So we can overlay all the maps that we have around equity and health disparities, and it will fit in exactly where the racialized, marginalized, indigenous communities are residing. And I think for me, this is quite important, because it's not just coronavirus that is really impacting, or it's not just diabetes, it's everything around health and well-being and social well-being that is particularly impacting certain communities. And it's not because of where they're living, it's because of who they are and how the system is serving or not serving them. So we have to look at COVID, the impact of COVID, and responses to the impact of COVID through the social determinants of health, if we need to really address the challenges that our communities are facing. This is another kind of a drawing or a diagram that stuck with me for a very long time, and I've adopted it from a famous epidemiologist and researcher in the States, Dr. Kamara Jones. And she talks about the social determinants of health and the social determinants of equity. And she's used the analogy of a gardener around addressing these issues. And I had the opportunity to co-present with her in one of those Black History Month presentation at Mount Sinai Hospital, where she was talking about how different disparities are impacting our communities, right? And so we'll see a lot of people walking towards this cliff and are falling down the cliff. And there is an ambulance here at the bottom that is picking up the stuff that the people, the people who are falling either, with broken bones, and put them in the ambulance to take them to health services, or maybe some of them would pass away and they're taking them to the morgue. And we'll see that the disproportion of the Black population in this particular instance, who are really walking towards this cliff. And responses to issues of health and social disparities traditionally are focused on increasing services here after people have been impacted, right? We will increase specialist services. We will, like we've seen mental health investment, for example, and those investments go to specialist mental health services and hospitals. When we know mental health problems and challenges actually happen in the community, and responses should be there either as prevention or early intervention. And I think when we're also talking about COVID and its impact in our communities, that is where we need to kind of start thinking about. And when I talk about this picture here, is we talk about it's a double-edged sword. We have to create a barrier to stop the walking and the falling down over the cliff, but we also have to fight barriers or remove barriers because people are not accessing services in the way that we think systems thinks, right? We've seen even with COVID response, the plans and the strategies that are being put out there do not always support and match the needs of communities. Now, a very good example we heard with the previous speaker when Melissa was talking about, if they had not started their own testing program, I'm pretty sure that the member of the indigenous communities accessing testing would have not been as much as what was presented to us. Is because number one, there is a relationship between the organization and the communities that facilitates access to services. Traditionally, and we heard earlier on with Dr. Timothy talking about the trust issue that has existed for generations between communities and healthcare systems, whether it's the ethical issues, the research issues that were, right? So that is a big barrier that needs to be removed. The other thing is also access to those services are not always easy, whether there is a transportation issue. And so those are the kind of responses that really have to take the social determinants of health and the equity lens in responding to either virus situations, pandemics, but also any kind of other healthcare services. And so it's a double-edged sword whereby we have to create barriers to stop people from going there. So our attention, our focus, our strategy should be upstream to try to see where can we start engaging people. In the Black communities, we are hearing and we have been hearing that there's a lot of myth and belief about COVID, the virus itself, and the testing itself. Already we know that It's good that we are hearing that there are some, good news around vaccination, but that's going to be a big challenge with our communities because there's already a lot of this, myth and disbelief because of real experiences and perspective that our communities have experienced in the past. So when we are addressing issues around COVID, or we have to take this into considerations. When we are planning, and I'm working with our local partners here in Scarborough to try to do that in terms of testing sites are being put out in different spots, in different locations, but not very good uptake, particularly from the Black communities. And so what we have started engaging with right now is we are approaching it from a three-pronged approach, where we are developing a communication strategy whereby we do some education, some awareness, and use that as an opportunity to engage with our communities to say, this is actually serious, right? We are being impacted more than any other communities. There are ways that we can work around prevention, and also testing would be important because this is about us. And then we are coordinating with the hospital and other partners to locate testing sites at different locations that would appear to be accessible to our communities, rather than just going to the hospital. A lot of people I've heard say that they really don't want to go to the hospital for testing or for any other reasons right now because they think that's where COVID exists. I think probably the hospitals are now more safer to go to because of all the protocols and guidelines that they have to put in place. But the perception of people to go to the hospital to get their testing done as a preventative measure. I think if they have the symptoms or they're not well, they definitely would have to go. But we want to target the people before it becomes a crisis with all the other kind of health care that we are providing. And then the other most important thing that has also been discussed earlier on is the testing is one thing, but I think the support that comes after that is also very, very important. We know that people, for some communities, even during testing, or if they are suspecting of contracting the virus, isolation might not be, or self-isolation might not be a possibility because of their housing conditions. There are already challenges with food security and income issues, and people are struggling. People are really struggling right now. And the longer the virus remains, the more dire the situation is going to be. And then there is also the stress component for people who are going through this, people who have lost their jobs, who have family issues, parents who are struggling to accommodate to the new learning style of their children and youth, right? The youth themselves are really struggling with adjusting to this new teaching online. And then the parents are now have become the teachers and the supporters of their children's learning with all the other stress that they have been holding. Now is the time that, there is another added burden on them. And that is also something that we're looking on. So what we're trying to do is, as people are engaging with the testing and the awareness around the virus and the pandemic, we're also putting out support services, whether it's providing them with, food security assistance. For some of them, housing is a big issue, and I don't know how that is going to be resolved. A lot of people are behind their rent. Eviction is looming. Mental health is a stress. Transportation is a challenge for some people because they are also frightened to go out. And then with our seniors, the first few months were okay, but now our seniors are beginning to really show their frustration because it's very important, particularly within the cultural and community perspective, the coming together, the physical presence and supporting each other. I mean, we did a lot of work over the years to break isolation by inviting seniors to come out and engage and have a network and a connection. And now, you know, we're telling them, no, stay home. And, you know, it's really challenging. And the longer, up until now, I think it was okay, they were managing. But now, you know, we do wellness check with our vulnerable seniors. And the longer this pandemic and restriction is going to be, you know, in place, they are going to be challenged. And that is also something that we're looking into and trying to connect them virtually. I mean, digital divide is a big issue for a lot of communities. When we started, when COVID hit, you know, we had to work very closely with our communities to continue with our programs and to move it, you know, on digital platforms. But a lot of our communities who are on low income, seniors who didn't have the capacity, the skill to engage on a digital platform has also been a challenge. And we've been trying to do that to support them through financial assistance if they didn't have any Wi-Fi, or even sometimes, you know, we got donations to also provide them with some smartphones or tablets. So at least there is some connection and engagement. But now that we have achieved that, they still feel that the personal connection is very, very important. And that is an added stress to their already very fragile situation. So it's a very complex challenge that we are facing. It's even challenge if we are from, you know, the indigenous, Black, racialized communities, and then within that intersectionality as well. I think that is also something that we need to think about. And so in responses, whether we are a health service provider, whether we are, you know, municipality, whether we are anybody that has the responsibility of addressing this issue, I think looking at it from a social determinants of health perspective and also the equity lens, whether it's anti-Black racism, anti-indigenous racism, homophobia, all those kind of things have to come together in our response. And maybe finally, I will talk about the notion of COVID recovery. And we hear about this COVID recovery a lot. And for some people, you know, my concern is when we're talking about recovery, we need to really understand what are we recovering from and what does recovery look like. For particularly indigenous, Black, and racialized communities, recovery cannot be going back to where we were before, because we were not where we were supposed to be in terms of our health, well-being, and social status outcome. Our recovery should be a little bit further, that would at least address some of the issues that we were facing before. And so the reduction of chronic disease, the you know, addressing the overrepresentation of our communities in mental health institutions or in child welfare systems. Our recovery should also address that. And you can see that it's gonna be like a double, maybe triple kind of a strategy, focus, and resources that is required to think about recovery in the BIPOC communities. It's not just going to be, okay, we will get back to where we were, because where we were was not where we were supposed to be. So I'll just end it there so that maybe we can generate more conversations. And thank you for the opportunity to be here today to share this with you.
Thank you so much. I turned on my mic about 2 minutes ago, and then you said I'm finishing up, so I didn't even have to give you the 2-minute warning.
Remember, we talked about this before, right?
looked like it was well in hand. Thank you so much. Thank you so much, Liven, Melissa, Roberta, for and again, I think you know, when you organize sessions like this, you sort of hope that people come from different perspectives, and I think it was you all complemented each other really well, and I know I learned tons. So I will open up the Q&A, and I will actually suggest to people write in your questions, and I'm happy to sort of help moderate that. Maybe I'll pick up on Liven's last point, which is you know, recovering from COVID is an opportunity for, you know, perhaps addressing some of those health disparities that led to the problems that you've all talked about. And so and maybe this isn't even a fair question, but I think one of the challenges when we start thinking about structural racism, structural biases, and how to actually address some of those, it almost seems like an intractable problem. And I guess, do you have any sense of where would be a good place to start if we were going to reimagine a world post-COVID where some of these health disparities are being addressed appropriately?
I think maybe the first place to start, it's for the system to really acknowledge that the issue is not just the pandemic and the virus. The issue is the systemic problem, and I think that would be the first place to start, with the acknowledgement. And then from the acknowledgement, I think the system making itself accountable to communities by either identifying certain actions in partnership with communities to say, here are 3-4 things that we need to do. We really see that this is a systemic issue and can only be addressed through a long-term strategy and systemic response. We've seen a lot of times, we've seen it also with pandemic, and sometimes it's also very important to have that. Whenever there is an issue, the response tends to be throwing money into the problem. And we need money, definitely, and from a community perspective, I will never shy away from investment into programs. But that alone cannot be a solution. I think because, we've seen it, for example, when we have a shooting, for example, we had the Danzig shooting. The government responded, the Ontario Black Action Plan, investment into programs. But when that funding is limited, right, 3-4 years investment, when that funding ends, everything stops and we go back to, so it's a cyclical kind of an environment that we are seeing. And so the response has to be with a long-term strategy, a systemic response should be that, and then to make the system to make itself accountable to communities to say, we are promising this and you should keep us accountable. I think that is going to be a good start from my perspective. If I may add, with the pandemic response, the government responded with a lot of investment. Great.
Yes.
Community, like COVID emergency response, we are able now to provide food security issues, but we're just doing that and nothing else is changing, right? So that's what I think we should be thinking.
Yeah, thank you. Melissa, I don't know if you have anything to add from your perspective.
I definitely agree with a lot of stuff that Liban has said. For sure, money is important. Investment is important. Just putting money towards a situation without a really good plan. We have seen that in a number of different ways. I think about the payouts for residential school, the payouts for the 60 scoop. Man, has it not been good for some community members, and I don't think they realize it, because I feel like levels of government are patting themselves on the back. Oh, we did good, we helped them, we gave them money. They had nothing else in place for program to support their mental health, to support their trauma. Guess what's going to happen? They could be sober and dealt with their work for 20 plus years, but all of a sudden you give this large bit of money and then it's and no other supports, and it's not a good, doesn't end up being good turnout. And I'm imagining similarly is going to be, again, based on this COVID, kind of what's going on right now currently and during this pandemic. I agree. They've done a lot of opportunities. I know a lot of Indigenous organizations and other organizations that are doing all these food hampers. And I've heard some clients tell me they have tons of resources now for food hampers, but it's like, it's more than just that. Food security is important, but again, once all this is done, hopefully sooner than later, of course, I'm sure like all of us are definitely hoping, understanding what the new normal is like. So how do you continue to support them later on down the line? What are the programs that are going to be in place? A lot of it comes down to these communities needing to understand what they need. When we talk about racism in some of these systems, when you think about what racism is, a lot of it comes down to beliefs or values, something you've learned over your life. And so we have to break down some of those beliefs and some of it comes through education and understanding, in different ways, because, again, I think about the video of the young lady in Quebec and what she endured before she had died. And I mean, I can't imagine, but I understand that I'm sure the health system there is not intending to provide treatment like that. Instead, that might be coming from more of the context of the staff being enabled to do that or allowed to do that. And nothing being necessarily done until this young woman had to post the terrible stuff. So again, like it does have to come back from another space, and it has to be inclusive of the different communities, of the Black community, of the Indigenous community. Find out what we need to do. Again, it's this idea of our health in our hands, and that's really supportive of all the truth reconciliation pieces, that have come up years ago about supporting our different ways of knowing, our different healing practices. It's important. It's a part of who we are, and it's a way that we can rediscover our identity in order to help ourselves understand how we can care for ourselves ongoing. So reclaiming ourselves is what the important piece. And I think that's what different levels different levels of government really need to understand and continue to support. Thank you.
Thank you. Roberta, was there anything you wanted to add to that?
I just wanted to add, I think it's important to look at who is benefiting from Canada as it is. Because I think, there has been money given, but I think the money, again, it's a bit of a tied aid of how it can be used, who it's given to, the organizations that are established. We know that, Black businesses, Indigenous businesses, small businesses are suffering. There's folks who are doing businesses without, they're not registered businesses, but they provide services for the community. So I think we got to look at the whole notion of who is Canada benefiting as is. And I think when we look at the, kind of adding to Levan and Melissa's conversation, accountability is really, really important. But I also believe in, particularly health reparations for the violence that has happened and continues to happen. And what that means is looking at funds, large funds, amounts of funds that could actually be resourced in a collective or collaborative community effort where, there's many different Black and Indigenous heterogeneous communities, queer communities, communities of folks who are living with disabilities, communities of, folks with different languages, et cetera, and really gender, et cetera, gender identity, and really have conversations of where these funds can go. But I think before we do that, like if we create these kind of notions of kind of paternalistic, ways of giving, no, we're not getting funds because, we can't create our own health services. We're getting funds because there's been a robbery of resources. There's been an impact of violence, particularly colonial violence, anti-Black racism, anti-Indigenous racism, and other intersectional violence. So ethically, I think when we're looking at, what can we do in terms of the notion of quote unquote recovery, we have to look at our whole system. And that kind of, the notion of decolonization has to do with our systems, our criminal systems, our justice systems, our educational systems. So even the notion for me of equity seeking, I think is, comes from a kind of a conversation that can actually happen within the system that we have today. And I think that needs to be talked about, that needs to be debunked. And we need to really talk about how we can actually create, health justice and not health injustice for our communities. So I'm kind of on the side of, I'm tired of anti-Black racism statements, saying that I'm against anti-Black racism, anti-Indigenous statements. Every bank is promoting this right now. When we go to the bank, can we get loans? Can we have access for resources to do things? When we are seeking housing, do we need to pay? Some people are paying 3 and 4 months rent ahead of time to get housing in Canada. So, it's when we talk about social determinants of health, which I think is really important, we need to not only talk about socioeconomic status without talking about the impact of anti-Black racism, because folks tend to say, okay, let's talk about the impoverished Black and Indigenous folks, but really talking about bigger things than that. And the last thing that I would say, also in terms of the environment, there's so many Indigenous communities who are not drinking clean water. There's so much, look what's happening in Nova Scotia in terms of fishing rights. So it's more than just, saying, hey, we can give you money for services. It's really decolonizing the practices of the Canadian system and creating real equitable change that will actually benefit not just white folks, but our communities also. Thank you.
Thank you. So I do see there's some comments in the Q&A. So maybe it looks like there's one comment and one question. So maybe I'll read out the comment and then we'll go to the question. So it was for you, Liben. Another intersectionality most people don't see are how people who have developmental disabilities and how, due to the longstanding lack of funding and resources, are often impoverished and homeless. They often lack the capacity to figure out how to even get services. Their symptoms are often minimized when seeking medical care due to the outdated ideas about people with developmental disabilities. So it's certainly, again, another intersection, I guess. So if anyone had any kind of specific comments about that.
I just think I'll say one thing about disabilities. Right now, COVID is going to change the way we think about disabilities and accessibility services, because people who are, are living after COVID are actually having many accessible or disabled effects, right, impacts. So I think that, when we're talking about developmental disabilities and we're talking about navigating the system, before COVID, it was very challenging. We know there's a lot of isolation in communities who are dealing with disabilities, and also that certain folks have some services, certain folks don't, depending on race, right, and indigeneity in terms of even dealing with those things. So I think that COVID is going to, see a lot of more conversations about how we actually create a more society that has, folks with disabilities and deal with the ableism in our society. Again, ableism is connected to racism, to sexism, to homophobia, et cetera. And for folks, it actually increases the violence. So I think it's about continuing, when we look at acts of violence, how it impacts other folks, depending on the intersectional pieces, is really critical. And that hopefully when we're doing justice work or justice-centered work, that we're going to do that it's going to help more folks, right? And we're talking about heterogeneous folks, and hopefully that we can create more accessible programs. But there's going to be a real issue when COVID finishes, and hopefully it will finish, regarding accessibility, because right now we're living in an ableist society that does not treat folks with disabilities or accessibility needs equal or fair.
Agreed. There's a question on rural communities. So again, that's another, I guess when you talk about different rings of privilege, I mean, living in a downtown urban environment where we have access to all of these services. So I guess any suggestions for rural communities? Limited resources, access to services, education are often an added barrier in addressing many social determinants of health.
If I can just comment, yes, definitely. I think the urban-rural divide is significant. When it comes to transportation, access to services, the digital divide nowadays, when you have to access services or many services virtually, it might not be possible for certain rural areas. And I think so this is, when you have a lens of the equity lens, this is what you will be able to identify and say, okay, there are certain groups, or there are certain geographical areas, or there are certain considerations we have to take in terms of our response. A general just response, one size fit all, is not going to be meaningful or helpful, right? So that's why the equity lens is very important, to look at what is the disparity or the equity issue that needs to be addressed in this particular community or in this particular region, geographical region, right? So rurality is a big issue. We know already there are access issues because of transportation, because availability of resources within that area and things like that. So that's what, the response being through an equity lens is going to bring out, whether it's, the different intersectionalities we talked about. Disability, cognitive development, all those kind of things. That's why the equity lens, I think, for me, and the social determinants is a good starting point to address those issues, and then develop different strategies for different groups or different environments to make it meaningful to those particular situations.
Can I just add one thing? I just also want to say that rural communities, there are communities who are suffering, but there are also folks who are leaving the city who have money, unearned privilege, and are going to rural communities during COVID-19. And, there's the housing, getting houses there, et cetera. And their access to rural communities, depending on your location, is not the same. So I can tell you for an African person or African identified person, us going to a rural community is usually experiencing increased anti-Black racism. And also having the access and funds to be able to move to a rural community is also not necessarily there for most folks. So I think it really depends. Of course, we have a lot of Indigenous people who are living in rural communities, which is a different experience. But I just want to say that kind of notion of rural communities as being one way, we also need to challenge in terms of how we think about rural communities.
Very good point. And maybe we could end off with a really good question around vaccines. And maybe this is a way the majority of the people that usually come to our conference are frontline healthcare providers. So I think we've gotten some good news this week that it seems like there's 2 vaccines that seem to be showing in phase 3 trials some effectiveness, which is very exciting. But given the distrust of the health system by many of these communities, and Liban, you explicitly brought that up, how do you suppose this could impact the uptake when the COVID-19 vaccine is available? Maybe I can ask a slightly, an aligned question, but a slightly different one is, so if you were designing that sort of vaccine distribution system, how could we ensure that we're, to the best of our ability, making sure that we're providing equitable access to the vaccine to arguably the communities that are most affected by COVID?
That's I think that's an important question. It's a complex situation, I think, but it's an important question, and I think it's going to be a test really to the system to make sure that we are supporting our communities already. At least I can speak of the Black communities, or at least the communities that we serve here. We already have challenges with, as I said, the healthcare system, but also with medication, right? I can give you examples of people who are diagnosed with diabetes or hypertension and not really following recommendations around medication. And it takes a lot of engagement, education, and conversation to get to that stage where there is a pathway towards really the end game being either managing your diabetes, your sugar level, or managing your hypertension levels. And we do a lot of education and engagement and negotiation through our diabetes education program, for example. I remember one time, we do report on diabetes education program, and the ministry has a kind of a performance indicator to say that the ratio of clients visit is, I can't remember, I think it's 1 to 3, or, like a client, the best kind of a ratio is if a client has a visit, has 3 visits to address their diabetes issue with their providers. Essentially, on average, essentially being the first time you're diagnosed, you are provided information. Maybe it's giving you flyers and saying, here is diabetes, here is the complication, just go make sure you read and understand. I will follow you up in 3 months, and then come back in 3 months and see how you are, and maybe give you either change medication or give you more direction, and then I'll see you in 6 months. Our report was through the roof, and they kind of asked the question and saying, this does not seem that you're providing an efficient service. And I had to ask and challenge and say, what do you mean? And this was explained to me, and I said, look, with our communities, it will at least take 3 visits for them to accept that they have diabetes, right? And then another 3 sessions if you are a very good provider to get them to start taking their medication, right? And then 3 visits to monitor and see how they are. And then plus you would have to refer them to other services where they have to come for physical activity programs. With diabetes, you have to have certain physical activity, prescribed for you. And if you are privileged, then you can go and join a gym and you are responsible, right? If you are on low income, you may not be able to enter a gym or have a membership. So our visit per ratio, like ratio visit, was like through the roof. And I had to explain to them and say, we can't do that, right? So I think the same thing with flu vaccination. We had some challenges with our flu vaccination. I think this year everybody's taking their flu vaccines, which is great. But we had to do an assessment and identify what was people's belief about flu vaccination. And then we did an educational campaign to our communities, and we increased our flu vaccination rate from 11% to about 50% within a year. So I think there should be an education, an engagement, a relationship building with our clients to make sure that they understand what this is and why this is, and build the trust. I don't think just expecting them to say the vaccine is here and come. I mean, it's gonna. So I think we need to develop the relationship through engagement, through education, through validating their concerns and their fears, and also what was described earlier on, bringing the historical context to say, we understand that this is a valid reason for you not to trust this vaccine because of the historical context, and then through that come to a pathway or a negotiation where they are able to make a determination based on facts and knowledge.
Melissa, I saw you nodding through a lot of what Lyman was saying. From sort of the Indigenous communities, it sounds like a lot of what Lyman said would certainly apply. I guess anything that we can learn about how we could make sure we do this well, from your perspective.
I totally agree with a lot of pretty much everything that Lyman said. Trust is a big thing. That's the only piece that's going to be there. They have to understand that it's a safe space for them to come. I've done presentations before where they've often asked me, how do we get Indigenous people to identify that they're Indigenous? Because that's what's going to happen. They're going to show up in your ER. They're going to show up in your place. They're not going to tell you they're Indigenous. Why? Because the bias comes with, there's biases that come with it. Oh yeah, okay, no, she's not having a stroke. Let's think something else about it. And as a CHC here, we've literally had to write letters and send our clients with the letters saying, I'm expecting you to see this client. So trust is huge. And I think that's going to be the piece, right? And again, I will often come back to this discussion of the importance of having a lot of these strategies to come from the community, for the communities to be supported, to be a part of these strategies. Don't get me wrong, allyships is important, and it's really, really, there's not enough Indigenous, I know I can say from ours, Indigenous health providers necessarily that can address this all. So of course, and having people on our side and to support us to do all this and helping build that trust and helping creating those culturally safe, culturally aware spaces that recognize that, there's so many other pieces, so many other factors that are within one person's health that, yes, I understand the person sitting before me is not just high blood pressure, diabetes and all these different illnesses in one. There's so much more to that person that brought them to where they are today. So really trusting in all that journey and supporting it. But I totally think it's exactly what I've highlighted before, in a sense of it needs to come, part of it for now needs to come from the community, and they need to understand. And the conversations, I think, coming from their supported leaders, I think for the Indigenous community here, in a sense of having the mobile unit, as well as that amazing in-person site that they have that's recently opened up for our community, and creating that awareness and space and giving us the opportunity to kind of take the lead on what our community may need, is what's needed right now, I think. And that's just the piece of that truth and reconciliation. It's that piece of basically giving us back our self-determination to that degree, right? And I think that's going to be a huge piece in helping share the importance of the vaccine when it does come out. And I'm sure there's still going to be a mobile piece coming from our area as well that's going to help address that. But I agree with Lyman. I think our flu shots this year have kind of gone through the roof. We've gone through them very quickly. So, in normal years, we're always like calling like, hey, you want to come in? But this year, it's just like everyone's on point. So I think it's going to be there. And I think they do trust the system to some degree. But maybe it's the trust right now of knowing that they're coming to a clinic that has their artwork on the wall, that, you know, that smells of our medicines, that really is welcoming and inclusive of where we all come from in our diversity. That might be the first step. And then after that, really, you know, finding our way to engage it across the board. So.
Thank you. So again, that theme of empowering the communities to actually help do this. I see that it's 1:31, but Roberta, I can give you the last word, just so I can be sort of equitable in the way we've distributed this. I
just want to, I think, echo what everyone else has said. I think planning, you know, for our community to be involved. I would also say that, you know, to also challenge notions of medical models. So yes, we need to use the medical model right now for the vaccine. However, there's folks in our communities who, you know, who use bush medicine, who use, you know, different things for healing. And when you go to the doctor, you know, that's not valued. So I think creating that, you know, trust in our Indigenous African and Indigenous medicines is really important. We need, it's a pandemic right now. We need to support folks to be able to get vaccine, but we also need to support people to get vaccines in an ethical manner, right? And creating the planning. I don't see the planning happening for our communities and vaccine delivery or that needs to happen. And that's scary, because I've talked to many people and people are saying, I'm not getting the vaccine first. They're not using me. So where's that planning that needs to happen? And that worries me, particularly when we see the rates rising on a daily basis. So, you know, let's start decolonizing our practice and our ethics through creating more social justice practices and more conversations and action within our communities, and giving us resources to do so. That's it. Thank you.
And there was one last comment just around, again, the disparity around education, which absolutely. Again, that's another example of you know, kind of the rich getting richer, so to speak, where they're able to have sort of these learning pods for their kids versus individuals that don't have those funds sort of continue to fall behind. So again, a good point. So I'd like to, I guess, call this first seminar to a close, although I think we could all probably keep going for another bit of time, but I want to be respectful of everybody's time. And just again, just a real heartfelt thank you to all of our speakers today for sharing your time and your wisdom. I know there's lots of all kinds of competing things, you know, you're being asked to do lots of different things. So thank you for spending the afternoon with us. And just to invite anybody to join us again next week, where we're actually going to be talking about the impacts of COVID-19 pandemic on people who use substances. And again, it's free and it's open to anybody that would like to join, including the panelists, if you want to come back next week as a guest instead of a panelist. So again, thanks everybody, and stay safe and be well.